I'd like to thank the organizers for the opportunity to present today. So the topic I was given was access to transplant after kidney allograft failure. This is a complex topic, in part because there isn't a lot of data. Most of the literature around access to transplantation is focused on the initial access to transplantation. But what I'm going to try to do is go over the limited data that does exist and try to provide some context to the work of the KDIGO effort here. So these are my disclosures, not financial, but they are related to the kidney allocation system in the United States. So as we all know, transplantation is clearly the preferred treatment option, right? So deceased donor and living donor transplants do significantly better than dialysis patients. And yet, despite this, the majority of incident ESRD patients aren't waitlisted. This is data from the United States that shows that we have over 100,000 patients starting or reaching ESRD every year, and yet we only have about 27,000 people being added to the waitlist in any given year. Worse still, when you look at just the incident population over the past 2 decades, despite numerous policy efforts, we have not really changed the proportion of incident ESRD patients that are waitlisted within a year of them reaching dialysis. So that number has essentially remained flat at about 15%. And socioeconomic barriers to listing continue to persist despite numerous policy efforts. So as you can see here, when you look at residential median household income and stratify individuals, those at the highest median household incomes clearly have the best access to either waitlisting or transplantation. And this has remained essentially unchanged over the last 2 decades, underscoring just how poorly we have been or how ineffective we've been at changing this strategy. This policy failure that has extended over multiple decades is particularly troublesome given the fact that it adversely impacts our youngest patients the most. So this is an analysis that looks at adult patients, yet patients in the 18 to 50 age group, right? Our youngest ESRD patients have actually had a decrease in the proportion of those individuals who make it onto our waitlist or get transplanted, to the point that currently less than 1/3 of these individuals are waitlisted or transplanted in the United States. And in the context of the conversation today, these are the individuals who are going to benefit the most from a kidney transplant, and probably the ones who are going to need a second transplant during their lifetimes, more so than anybody else. Now, the kidney allocation system changed in 2014. One of its changes in an effort to lower disparities was to change how allocation time is calculated. So in the United States today, allocation time is calculated from start of ESRD, that is when patients are started on dialysis, as opposed to when they're added to the waitlist. What that has done is it has changed the sense of urgency that patients and providers feel for getting on the waitlist. And as a result, we have essentially lowered the proportion of ESRD patients that are currently on the waitlist. So as of 2018, we had essentially wiped out 2 decades worth of progress. And now we are at the lowest point in terms of the proportion of prevalent ESRD patients on the kidney transplant waitlist. Now, granted, this is also in the setting, unfortunately, of improving long-term patient and graft survival. So as you can see from this analysis from Hariharan's group that was published in the New England Journal recently, clearly long-term outcomes have improved. How significant those improvements are remains to be seen as we follow the most recent cohort in this analysis out. But clearly there is a dramatic improvement in long-term outcomes, and we're talking about 15, 20-year outcomes. What is, however, notable is that these long-term outcomes have been driven, in part at least, by increased patient and organ selectivity, right? We have gotten much better, if better is the right word, at picking the organs that we want to use and the patients that we want to transplant. And many of these patients, despite the fact that we are going to have significantly improved long-term outcomes, are going to need a second transplant. So we're talking about dramatically improved outcomes at 15 years. So we're talking about a 50% survival for the 2004 to 2007 cohort, right? But that's still not good enough if you're receiving a transplant in your 20s or 30s. You are definitely going to need a second transplant. The idea of excluding retransplantations from all of our analyses so far is perhaps something that we're going to have to revisit. Now, as I said, there is increasing selectivity of patients being waitlisted for a transplant today in the United States. And as a result, mortality rates are dropping quickly. So even though our annualized mortality rate for the end-stage kidney disease population overall is about 20%, mortality rates on the waitlist approximate about 5%. Not only is mortality rate dropping, we're becoming increasingly more selective in terms of who we leave on the waitlist. So removals from the waitlist have gradually been increasing over the past 2 decades, to the point now that median survival for patients removed from the waitlist is approaching 5 years. Despite the fact that transplant centers are removing them because they deem them ineligible for transplantation. This increasing selectivity of patients is now being paralleled by an increasing selectivity of organ donors. So the green line is the line of proportion of prevalent ESRD patients that I've already shown you. The brown line is the proportion of deceased donor kidneys being discarded. As of 2021, that number has now reached a shocking 25% of kidneys are being discarded in the United States. So clearly we've gotten very selective about organs and patients, much to the detriment, I think, of our own patients. Now, with the increasing number of kidney transplants in the United States, the percentage of waitlist registrants with a prior kidney transplants, while the absolute number has remained relatively flat after an initial surge in the early part of the century, the relative proportion of registrations with a prior failed allograft as a proportion of all registrations has been steadily declining over the last 15 years to the point where it is now approaching about 10%. And similarly, the proportion of recipients with a prior kidney transplant, while the absolute number is going up, the proportion is decreasing because it hasn't kept pace with the rate at which kidney transplants have been increasing in the US. Despite the fact that our prevalent ESRD population with a transplant is increasing, we now have almost 230,000 patients with a working kidney transplant in the United States. A large number of those individuals are going to have a failed allograft and are going to need a second transplant. So with that in mind, this trend is somewhat troubling. And this is not a US-centric phenomenon. So in terms of data from outside the US, if you look at Eurotransplant, re-registrations are also declining in almost all the countries in the system, except perhaps the Netherlands, which has seen a small uptick in the absolute numbers, but still a relative decrease in the overall percentage. So similar to the US, they're also seeing a decline in re-registrations where they went from close to 15% in the early part of this decade to more recently about 13%. Not quite as dramatic as in the US, but nevertheless a downward trend that should trouble all of us. So what is the waitlisting rate with a failed allograft in the US today? So this is data from Jesse Scholl's group that shows clearly, not on the left, that retransplantation or relisting for transplantation, while there is a initial uptick in the first year after graft failure, that starts to plateau fairly quickly to the point where we plateau at about between 40 and 45%. This is the cumulative incidence function. So 45% of individuals that eventually relisted for transplant, when we go out to the 6-year mark. More troubling, however, is the proportion of these individuals who are being waitlisted over time. So depending on the year of failure, clearly you can see that there is a drop in the listing, and the preemptive listing is also dropping quite dramatically. So clearly we're becoming more conservative and less willing to relist individuals with a failing allograft. This is not just unique to adults. This is also a problem among pediatric patients. So individuals, this is data from Dori Segev's group that showed, it's a few years old at this point, but it basically shows that a little over than half the pediatric recipients of a kidney transplant are subsequently relisted and retransplanted over a 20-year window. That's a shockingly low proportion, and unfortunately that proportion is not uniform. It's also affected by significant disparities. As you can see from the figure on the right, non-Caucasian children are less likely to be retransplanted than their white counterparts. Again, going back to the adult cohort, disparities in access to transplant are similar to those that we see in disparities in access to transplantation. There are small gender there are definitely gender disparities that tend to become smaller as we look at older individuals. We've already talked about this trend over years. Private insurance individuals are more likely to receive a retransplant than those individuals with public insurance. And there are racial disparities that put African American and Hispanic patients at a distinct disadvantage compared to their Caucasian counterparts. Now, the proportion of patients relisted at any given point in time is a little over half, 57%. And yet, when you look at concordant listing, that is listing of individuals who get relisted at the center that they got their initial transplant at, that number is shockingly smaller, right? It's only about 3/4 of those individuals are relisted at their own transplant center. Now, one could argue that this is because patients move. And so it's a little bit hard to determine whether these are patient choices who've chosen to go to another transplant center, particularly for patients who live in urban areas or in regions of the country where there are 2 or more transplant centers as a potential option. But among the patients who are relisted at their transplants, what's particularly notable here is that of those 16,000 odd patients, only 6,000 odd patients actually get a preemptive listing. So that means even among patients who are relisted at their own transplant center, who have a failing allograft, only a third of those individuals eventually get relisted preemptively, suggesting that transplant center is actually failing these individuals in getting a preemptive transplant. Now, of course, preemptive transplantation, it's particularly from deceased donor list, is not standard allocation policy across the world, but it certainly is the standard allocation policy in the United States. And it's something that would give individuals an advantage because it leads to better outcomes and creates the opportunity for them to go from one allograft to the next without being exposed to dialysis. Now, not surprisingly, we also see educational attainment as a significant factor here. The greater the educational attainment, so you can see below, the greater the chances that the individual is going to end up getting relisted at some point in time. And there is large variations in practice, right? So this is across all the kidney transplant centers in the United States. As you can see, about a third of transplant centers have a standardized relisting or transplant rate that's statistically above 1 when you look at the standardized incidence ratio, but about more than half these centers have one that is significantly below 1. So clearly more than half of our transplant centers are failing even with the low standard that we've set across the country. And just to provide some context, right? So as transplant nephrologists and transplant centers, we're quick to blame dialysis facilities about their failure to refer patients for waitlisting. And the fact that for-profit dialysis facilities in particular are associated with even further reductions in access to the waitlist. But just to provide that frame of reference, we're talking about an adjusted hazard ratio between for-profit and profit dialysis facilities, about a 13% difference with an adjusted hazard ratio of 0.87. And yet when we look at transplant centers and what happens to our patients when they have a failed allograft, in the first year, transplant ESRD individuals with a failed allograft in their return to dialysis all have a significantly lower hemoglobin, and they tend to have, lower albumin levels. They tend to have, yes, they have slightly higher fistula rates, but those people who are naive to dialysis, who first start on dialysis, quickly have higher fistula rates, in part because they probably have maturing fistulas, which we have not set up our patients for. Clearly underscoring the fact that we could be doing a much better job about preparing patients with a failed allograft. Now, significant disparities exist in access to preemptive transplantation. This is the opportunity to get waitlisted with a GFR of 20 or below, and then get access to a transplant. We're not talking about living donor transplants here, we're talking about deceased donor transplants, and clearly there are differences both by race and insurance status in the United States. But that is not unique to our retransplantation problem. So yeah, clearly there is an age, race, and gender, and a BMI factor that influences preemptive listing opportunities or transplantation. But perhaps more concerning is the fact that residential distress index has a measure of socioeconomic status and educational attainment, as you can see here, clearly impede access to preemptive retransplantation. And this is particularly concerning given the fact that these are individuals who have already navigated the process of being evaluated and getting on the wait list and getting a transplant to begin with, who already appreciate the benefit, both clinically and from a quality of life perspective, of having a kidney transplant. And yet, despite that, they're running into trouble. The other notable finding here is that time to graft failure from the primary transplant, that is the duration for which these grafts were working, also appears to have a dramatic effect, suggesting there may be there are some biases of transplant centers that are doing a better job of waitlisting preemptively those individuals who have had allografts for much longer. Now, this is troubling in many ways. One is those individuals who have had allografts lasting 5, 6, 7 years are much more likely to have been referred back to their community nephrologist or the general nephrologist. And so it's hard for us to think as transplant nephrologists that we can actually take credit for some of this. So do inequities exist for undergoing preemptive kidney retransplant? Clearly, the answer is yes. This is another analysis from Rose Mannon's group that shows clearly that employment status, educational status, race, and gender all seem to impact access to preemptive transplantation. And that preemptive transplantation, just like when you're doing it without a prior transplant, has a clear benefit to remaining on dialysis. This is analysis from the Eurotransplant cohort as well. This is data from the Austrian group that shows clearly that there is a benefit to the second transplant. Although that benefit appears to diminish with increasing time spent on dialysis between the first and the second transplant. This is data from John Gill and his group that essentially demonstrates the same thing, that shows that patients who have had a prior allograft, yes, once they get on the wait list, are more likely to get a transplant and have a slightly increased risk of graft loss, but that still provides a significant survival advantage to remaining on dialysis. Now, the other thing to note in the literature is who do we give access to for retransplantation and what should we consider? So clearly the number of individuals requiring retransplantation is going up. But the question becomes, should we be limiting retransplantation options to certain individuals? This is an analysis from Heafy et al. That seemed to suggest that there were differences in graft survival of the second transplant based on how well the first transplant did. And they dichotomized individuals who got 79 months or more and 79 months or less of graft survival. That's 6 years or greater. And in an era where we're trying to push for the use of less than ideal organs, it's not clear that patients have the ability to control that, nor do they certainly have the ability to control what their GFR is at the end of the first year. So the idea that we should use these sort of clinical parameters that patients have no control over to determine whether people have access to retransplantation is somewhat troubling and needs further study at the very least. Well, what about factors that patients do control, like medication adherence? Well, if you assume for a minute that patients do control adherence completely, this is analysis from the University of Minnesota that looked at 100+ patients who had overt evidence of non-adherence and looked at what happened to those individuals who got a subsequent allograft. That is, they went through a reevaluation process with recognition of their prior non-adherence, were approved for transplantation and got a subsequent transplant. The numbers are small, but I think it's informative, right? So not surprisingly, those people who were non-adherent to begin with did slightly worse than those who were adherent in their first transplant. Whether the underlying reasons for the adherence were clearly completely addressed or not is not fully understood here, but clearly if you assume that they went through a reevaluation, one would imagine that the transplant center was looking at that. So these individuals had lower patient survival, higher graft rejection rates, both acute and chronic. But clearly, these individuals had significant survival benefits. These individuals did better than if they had remained on dialysis. And it's not clear that the difference between them and the prior adherent patients was, while it was statistically, it's not clear it was clinically significant. And what's notable is in their 100+ patients, a quarter of patients, the primary reason for non-adherence was financial. Another quarter was children. right? We're talking about pediatric patients, and to penalize pediatric patients as for being non-adherent as children, I think goes against what we're trying to do as transplant professionals. And a full third of these individuals had psychiatric issues, including depression, that underscores the need for us to provide better psychiatric support for these individuals as we help them move towards the second transplant. So in summary, retransplant registrations are declining despite the rising prevalence of kidney transplant recipients. This is a particularly concerning trend and something that needs a more understanding of. Factors that impede access to transplant also appear to be impeding access to retransplantation. This is somewhat of a surprise and particularly concerning because this is restricted to those patients who have successfully navigated transplantation already, who understand both the benefits of transplantation, but also understand kind of the complexity of the evaluation process. And these are patients who are purportedly under the care of a transplant nephrologist or a transplant center. And it's particularly concerning that those patients who are more likely to have been referred back to their community nephrologists appear to have significantly greater ability to get relisted and retransplanted than those who remain under the care of the nephrologist, transplant nephrologist. The fact that we are providing poor care and poor measures of care in the first year after allograft failure suggests that as transplant nephrologists, we clearly need to be doing better by our patients with failing allografts. We have to remember that retransplantation needs are disproportionately greater among our younger recipients, particularly our pediatric patients who are likely to need a second transplant. And we have to do better if we're going to ensure that these individuals benefit from transplantation. And then preemptive listing and allocation systems that encourage this approach are underutilized and suffer from the same disparities and the same challenges that overall retransplantation does. And even for those transplant centers that relist their own patients, this is particularly concerning, given that less than a third of our patients who are listed by our own transplant centers are relisted preemptively. I'll stop there. Thank you very much for your attention. Happy to take any questions.